Hi, everyone. This is episode 1 of Dr. Brown's Psych Commute, where I'm going to be talking about topics that come up in psychiatry and medicine as I drive to and from work. And today I wanted to talk about catatonia. Um, I've had a number of patients recently with catatonia, and so it's been on my mind. I wanted to start with just the fact that in the inpatient setting, some research some research suggests that as much as 20% of patients will have catatonia to some degree. And honestly, in my experience working on the inpatient unit, that's been about accurate for me. So, if you're seeing if you're capped at 10, you'd expect at least one of your patients to have catatonia on average. And so far, that's been about right for me. But sometimes it's not obvious. So I've had patients where catatonia was missed and they were admitted for quite a while before we picked up on some subtle signs. And lo and behold, an Ativan challenge revealed significant improvement. So the other thing I wanted to mention was that catatonia can sometimes happen abruptly in episodes. Usually it's more of an indolent kind of course, but sometimes it can happen abruptly. I've had patients where they are doing just fine, no obvious catatonic symptoms, and then all of a sudden they have an episode where they get rigid and stuck and mute and all the other kind of classic findings of catatonia. And of course, they get better with an Ativan challenge. So, speaking of an Ativan challenge or a lorazepam challenge, that is the preferred medication to use to both help with diagnosis and the treatment medication. Part of that is because of the pharmacokinetics of lorazepam. Catatonia seems to need a high peak concentration of a benzodiazepine. So delivering a benzodiazepine, particularly lorazepam, intravenously is going to be the most effective typically, and you're going to see results or some sort of response if it is catatonia, often within minutes. So things like clonazepam or other kind of slower peaking medications, you're not going to see much of a response, if any. And I've tried, so for one reason or another. However, on the inpatient unit, we generally don't do IVs. So if you're seeing someone in the emergency room as a consultant, that might be a possibility, but we're generally not putting IVs in on the inpatient unit. So the next best thing would be intramuscular Ativan. And generally, we're going for 2 milligrams. If you're doing IV, like I said, you're going to be reassessing for response within a few minutes, really. If you're doing intramuscular, you're going to be reassessing for response within maybe 20 to 30 minutes. And you can do a lorazepam challenge orally. So I will often give a 2 milligram Ativan challenge by mouth when IM is not ideal for whatever reason, or per patient preference. It still works. It doesn't work as well because the peak concentration is lower, but it still works pretty well in my experience. But you've got to wait for about 1 to 2 hours before you reassess. And again, that's just based on kind of the peak concentration pharmacokinetics there. So catatonia, the best way to screen for it is the Bush-Francis Catatonia Rating Scale. I believe the total is 23 items, but the first 14 are used for screening, and it only takes 2 or more positive to be a positive screen and warrant further investigation. And you're going to want to investigate your patients by physical exam too. A lot of times, and this is not only for catatonia, but assessing for extrapyramidal symptoms Parkinsonism, just uh, looking for any signs of rigidity at the wrist joint and elbow joint. That's usually pretty sensitive for EPS in my experience. And also signs of catatonia. Sometimes I'm surprised. I'll do a passive motion examination on a patient and, lift up their arms and try to move their joints. And then I let go and their arm gets stuck. Then I can move it around and it's clear that it's waxy flexibility. And I really wasn't expecting that because some of the other signs of catatonia weren't obvious before I did the exam. So I think physical exam is really important, especially that musculoskeletal component. Also, subtle signs that I found useful are things like negativism. So if you ask a patient something and they sort of immediately want to do the opposite or reject it in sort of an automatic way, sometimes that can be the sign of negativism. And in one case, that did point me toward, this is a little bit unusual. And that was really the only sign that jumped out at me that warranted me to do further investigation. And then I did a lorazepam challenge, and the patient had a significant recovery and was able to be discharged much sooner than otherwise had I missed that. Now, if someone does have a positive Ativan challenge, lorazepam challenge, then you're going to want to schedule the lorazepam. And usually I start with 1 milligram TID. And if they've truly got a lot of frank catatonic symptoms or signs, you're going to probably be able to ramp that up pretty quickly. In some cases, I've gone as high as 20 milligrams a day, and the patient has no signs of being oversedated. So I'll keep ramping up until there's signs of side effects or until there's a plateau in effect, generally. So lorazepam, I usually start 1 milligram TID. I might go to 2 milligrams TID and kind of just keep ramping up like that. If someone's got a number of comorbidities or they're older, then I might go a little bit slower than that. But again, if they've really got frank catatonia, they're going to be able to tolerate it just fine. If lorazepam is not working and you're sure they've got catatonia, or lorazepam's effect has plateaued and their catatonia has not fully resolved, then electroconvulsive therapy, ECT, would be the next step. And in my experience as a ECT practitioner, patients with catatonia are usually very responsive to ECT. So for depression, when we're using ECT to treat depression, usually we say, we don't expect to see some response somewhere in the range of like 6 to 12 treatments. And generally we're doing 3 treatments a week. So, that translates anywhere to 2 to 4 weeks of treatment. But with catatonia, I've seen significant response after a single treatment, more typically somewhere in the range of 2 to 4. So significantly fewer treatments than for other indications of ECT. And the other thing is they tend to stay better. If you get someone fully out of a catatonia with the ECT, they're often better for a while, although some people will need maintenance treatments, like with other indications. So that's pretty much what I wanted to say about ECT, or catatonia, rather. I think it's a fascinating syndrome. And, I guess I should mention, that always catatonia is secondary to something else. It's like fever in that regard. It is a sign, but there is some other cause of it. And so you can't just treat the catatonia without paying attention to and trying to identify what is causing it. In my practice setting, being an inpatient psychiatrist right now, most of the time it's related to schizophrenia, or some other schizophrenia spectrum disorder, or a severe bipolar mood episode, but it could be due to a medical condition. So you've got to have a wide differential. So any brain insult in a way could yield catatonia. Other things that it could be that could look like catatonia, potentially just extrapyramidal symptoms, some kind of dystonic reaction, Parkinsonism might look like catatonia. Non-convulsive status epilepticus would be something else to consider on your differential if you're considering catatonia. And I think I misspoke earlier when I said 20% of inpatients are likely to have catatonia. More like 10%, although I have seen some statistics up to 20%. In my experience, it's more likely 10%, just trying to be careful about catching these patients in my own unit. And the other thing to keep in mind is that although catatonia is often most easily recognized in its sort of stuporous version, there is excited catatonia. And sometimes we just attribute that to agitation or whatever it may be. But if it's really constant hyperactivity that doesn't appear to be goal-directed or purposeful, that really could be excited catatonia. And we're going to end up treating it in the same way. All right. That's pretty much all I wanted to say about catatonia. And I'm pulling into my garage now at work. So we'll leave it there. Thanks.